Hello, and welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today, I am joined by Dr. Channon Hudgins, who is a hospice and palliative care medicine doctor in Texas. Welcome. How are you?
I'm hanging in there today. It's good to see you, Mary. As you know, the days have been very stressful with this fourth surge of COVID, especially as a palliative care physician inside of the hospital. And we'll kind of talk further about that.
Definitely. Texas has definitely been across the news channels recently with everything going on there. But
Yes.
so we have a lot to talk about, but let's take a step back and talk about hospice and palliative care and what that means to be a hospice and palliative care physician, and how did you get there?
Yes. So I'm always asked this question, and I have a fairly unique journey into palliative care because most palliative care physicians, their primary training is internal medicine or family medicine. But my primary training was as an OB-GYN. And when I was exposed to OB-GYN as a medical student, I loved it. I thought it was great to combine women's care with delivering babies, doing a little bit of surgery, doing clinical work. And I completed my residency and quickly found out, or it took some time, but quickly came to the conclusion that while, yes, there were a lot of fascinating things about OB-GYN, it was just an overwhelming lifestyle for me. I have friends who are OB-GYNs who love it, and they're doing great. They're thriving professionally and personally. But for me, I felt like I wasn't thriving professionally, and that's just me.
Right.
And so it took some time, took some years, but I finally came to the conclusion it wasn't an easy decision to give up something you love, but it's not working out for you,
Right.
kind of like a relationship. um, but in my journey to figure out, well, what am I going to do next? What's going to give me the opportunity to make good change professionally and
Right.
still help people, but still have a lifestyle balance that works for me. And after asking a bunch of questions and learning about different specialties, I landed upon palliative care, and I met with a program director with palliative care program in Houston with training. We sat down. I told her kind of what I was hoping for and kind of what was working and what wasn't working. And a lot of the principles with palliative care and OB-GYN overlap.
Yeah.
You're doing a lot of symptom management. It's not just one patient, you're treating the whole family and having some awkward conversations, as you can imagine, as an OB-GYN. And then with palliative care. And so I completed that training and have been in this ever since it's been about 5-6 years now.
That's
I've been
crazy.
palliative care.
Yeah, so when we met, you were making that transition. I really did
Yes.
not remember that it had been that long. Yeah, that's crazy.
Yeah.
And so before you go on, because I'm going to ask you the follow-up question, but I really want to underscore for those who are listening that just because you choose one route in medicine does not mean that that's where you have to stay. I think we are often, as medical students, I felt that pressure of like picking the right residency because, this is what I'm choosing this life for the rest of choosing this career for the rest of my life. And that's not really the truth. Like if you really get into something and it's not the right fit, and that's okay. And you figure out what is a better fit and figure out how to make it work. And then you bring an extra set of experience and skill to the second thing that you choose that makes you very different and unique than people who came from a different pathway. So I'm glad you shared that part of your story with us. And then speaking about hospice and palliative care, I know some people use those interchangeably, and that is not right, but those are not the same words. They are not the same thing. And I know often when people hear the word hospice, they have a negative reaction. And so explain to us the difference between the two fields, and try to allay people's kind of natural hesitancy or fear when they hear the word hospice.
Yes, yes, you are correct. A lot of people will use palliative care and hospice interchangeably. A lot of doctors, nurses, a lot of times I notice that a lot of medical staff will say palliative care when they're really trying to counsel a patient or family about hospice care, because you're correct, hospice is a trigger word for a lot of people. So, but there is a difference, and they are a part of the same umbrella, but there are distinct differences. So, palliative care is dealing with quality of life issues in patients who have a chronic disease that we're not necessarily going to cure, but it's not necessarily terminal. And so palliative care can be given in the hospital. So I see patients who have a chronic disease in the hospital and just help them talk through things, help them with symptoms, help them determine what's quality of life to them, and help make plans moving forward. And even outside of the hospital, there are palliative care programs outside of the hospital. There are palliative care clinics, there are palliative care home companies. And basically what palliative care does, let's say, for example, you had congestive heart failure. Well, that's something that we're not going to cure. Depending on the cause, you're going to have that forever, although there are some causes where CHF is temporary. But if you have congestive heart failure, you may have shortness of breath that really affects your quality of life, your ability to work, or your ability to play with the grandkids, or what have you. So what palliative care does is they provide symptomatic support. So helping to alleviate that sensation of shortness of breath while you're still following up with your heart doctor and all your regular doctors. They're just adding an additional layer of support. And they also help you talk through things, help you complete advanced directives, which I'll talk about a little bit later. And they follow along throughout the disease process. And just congestive heart failure, the cardiologists are doing great work, and that is something that could be managed for years. And some patients, depending on the condition, maybe even decades. So palliative care follows along that disease trajectory. Hospice care is more, think of it as dealing with quality of life, keeping a patient comfortable when they are end of life, meaning when we think they have a prognosis of 6 months or less. So when your disease process gets to the point where medicine is no longer improving your life, or you decide, hey, I don't want to continue to be treated this way, or I'm tired. I just want to rest and be at peace and be at home with my family and spend this moment of my life relaxing. Then that's what hospice care is. The focus on hospice care is to keep a patient comfortable, alleviate any suffering at the end of life. Patients on hospice are no longer seeing their doctors, no longer seeing their cardiologists. Hospice takes over their care completely, and they try to make things easy for the patient and family, and really support a patient and family at a very difficult time in everyone's life. And hospice can be done at home. It could be done at a nursing home. Some hospices have facilities for patients who qualify. And every state does hospice a little bit differently. So I'm just speaking in very broad terms. But a lot of patients do choose hospice, and they think, a lot of people have a misperception. Medicine is always evolving, including hospice. There was a time when hospice just meant you go on morphine and, be at rest. Whereas hospice, unfortunately, is an underutilized service. We a lot of times wait too late and miss that opportunity. But patients travel, well, not anymore with COVID, but
Right.
patients on
Not
hospice
right
can take their,
now. Right.
have traveled, abroad if they're still able. Hospice, on hospice, it's not as if everything just stops. They can still do oxygen, they can still manage fluid, you can still continue a lot of your medications for like diabetes or hypertension. And so, and some hospices will continue dialysis depending on the circumstances. So it's not all or nothing as it used to be.
Yeah, and I think just to underscore that hospice does not mean, I've heard people that means, oh, we're giving up. It doesn't mean you're giving
Mhm.
up.
Mhm.
There are some, to your point, there are some treatments that you can still continue, but it's
Uh-huh.
when you come to that point where you know that you don't want people to be suffering and in pain and
Mhm.
um, making comfortable decisions when they still can, and
Mhm.
when they're still able to, so that they can,
Yes.
have the most quality of life in those last days, however many days those are. And it might be 5, right? Or it might
Mhm.
be 6 months. And sometimes,
Mhm.
like you said, medicine evolves, something pops up, and you might come off of hospice, right?
Yes.
Depending on what
Oh, yeah.
happens.
Oh,
So,
yeah. Hmm. Yeah, we definitely, somebody's time of death is between them and a much higher power than any doctor on the planet. And hospice does not do anything to speed up the dying process or slow it down. It's just to keep patients comfortable. And you're correct. Sometimes there are certain disease processes where when a patient is terminal, and the condition is terminal, sometimes patients actually live longer on hospice than they do continuing traditional medicine, because as the body starts to break down, sometimes the interventions we do, particularly things like chemotherapy that can be really tough
yeah.
on your body, may speed up the dying process. So sometimes, and just the stress of being in and out of the hospital and
Mm-hmm.
not having your pain well controlled, sometimes patients actually live longer because you go home, you relax,
Yeah.
you rest with your family, you get all the pain medicine you need, and let nature
Right.
take its
Of
course.
course. And
Mhm.
and you mentioned kind of thinking about these conversations you should have with your family, with your friends, with your children, depending on how your family structure is set up. Because we know all of us has a day in store. How and when we get to that day is determined by somebody other than us.
Yes.
But as much as we can do to prepare for that, especially, for ourselves as individuals, but more so for our family and friends and loved ones, so that they know what our wishes are when we get to those days.
Mhm.
Talk a little bit more about the advanced directives. What does that actually mean? When should you think
Mhm.
about it? What does it
Mhm.
entail?
Yes, absolutely. So, one, health disparity is actually involved with advanced directives. As we know, the Black population is at risk for diabetes 2 times more than the white population, as well as heart disease, stroke, hypertension. And that's a whole nother
Yes.
discussion for another day.
It is.
But when we survey, we find that only about 24% of Black people have completed advanced directive as opposed to 44%. And that's another health
Yeah.
disparity. Maybe they don't have, the primary care doctors to help them fill that out, or there's just a lot of misunderstanding about it. So basically, advanced directives, and this is something that we all should really be discussing,
Mhm.
especially now that we're in a global pandemic and we're not promised tomorrow.
Indeed.
There is no defined time to complete it out, to complete them. I tell everybody, if you're over 18, you should probably
Mhm.
consider it, but particularly as we get older and you start to develop um, major health problems, anytime you're diagnosed with a major long-term health problem, you should probably consider filling that out at some point. And then also talking to your doctor and researching um, the disease trajectory. If you have a loved one diagnosed with Alzheimer's disease, you might want to learn about the typical pattern and how long someone would live with that and what's the normal disease process. Basically, what advanced directive paperwork is paperwork that each individual fills out that lets not only the medical team, but your family know what you're thinking if you get really, really sick, if you get to a case where your condition is terminal, despite whatever medicine you're being given or interventions you're given, or you have an irreversible condition that makes you very debilitated. And another part of advanced directive is called a medical power of attorney. If you don't fill out any other part of advanced directive, you should designate a medical power of attorney. And basically what that is a person that you designate to speak for you when you can't speak for yourself, and they help make medical decisions for you. And you can designate one person and have two alternates. Check your state. Each state legally has a different form. So you can check the advanced directives for your state. And usually it requires two witnesses who are not family and not involved in your medical care, or you can do a notary. So you don't have to go to a lawyer. These can be completed free of charge. And it's just really quick. It just requires that person's name and phone number and a conversation with that person. So I've had situations where a person filled out a medical power of attorney, did not tell that person they were their decision maker. Then I'm in Texas, they call in New York, and they're like, what?
Wow.
So make sure whoever you designate that they know that they've been designated. They don't have to sign. Only you can sign. Nobody can sign for you.
But they should know.
But they should know. And they should know what your wishes are. If I get really, really sick, I don't want to be on machines, or I don't want really aggressive care. I just want to be comfortable, or I do want everything that they can do medically to try to keep me alive. And really, these conversations, people think these conversations are about death. And in a sense, yes, they are, but it's also about living. What is quality of life to you? I hear a lot of patients say, hey, my loved one said they didn't want to live as a vegetable. But as you know, and I know, that's a very broad term, medically kind of ill-defined. I would encourage everybody to be a little bit more specific. For instance, I had a patient who had told his family, if I get so debilitated where I can't even sit in a chair and play with my grandkids, that's not quality of life for me. If I get that debilitated, let me be comfortable, let nature take its course, and put me on hospice. And the family, they were, understandably upset about it, but they had their instruction. He had told them multiple times, and they knew what to do, and they, felt honored to, carry out that wish. So that's mainly what advanced directive is. So medical power of attorney, if you don't do anything, do that first.
You don't hear anything else. Medical power of attorney.
Yes.
And so you mentioned a couple of things. So we're talking about advanced directives. We're talking about a moment in history that is very unique to all of us living today in this COVID pandemic, and that it is still going on. And surge number, we won't even say, Lord help us. But it's I think most of us, when we think about COVID, it's like, oh, you get COVID, you basically either you get over it and you're fine, or you don't get over it and you unfortunately pass away. But there's some in between in that. And so tell us about the patients that you're seeing who, have gotten COVID, but are needing long-term care.
Yes. So COVID has been devastating. And I am a frontline medical worker. Obviously, I deal with a lot of very, very sick patients, the sickest patients in the hospital. And this surge is continuing, and it's unfortunately getting worse. And last year was particularly difficult. This year is still a lot of the
Yeah.
same. Unfortunately, 90% of the patients that I'm seeing who aren't doing well or in the ICU or not surviving are unvaccinated, over 90% at this point. So it's very urgent. I know that the vaccine, nothing we do or give in medicine is going to be 100% safe or without potential side effects. But when you weigh the side effects of the vaccine versus the COVID infection, is not even anywhere near in the same ballpark. And to see patients suffer like this when we have a tool to, not a perfect tool, but we have a tool to prevent severe infection. It's just been devastating, mind boggling. And so I am obviously pro-vaccine.
As am I.
As long as you don't have any contraindications, I believe that everyone should get the COVID vaccine, because you don't want to be that person who unfortunately gets a severe case, and we could prevent this. Obviously, we continue to treat all patients with the utmost care and respect. But I do have a lot of, I'm a pro-vaccine person. I've always taken vaccines. I've never had an issue with it. I'm appreciative of all the vaccines that we've gotten throughout generations that allowed our grandparents, our parents with the smallpox to survive without debility beyond childhood. And I that's the way I feel about the vaccine. Yeah,
definitely. So I mean, so much has happened. We've learned, I think, so much about medicine, about health inequities in this country, about just, our political climate and how that influences health policy. It's been a lot of learning across the board.
And one thing I learned is that it was actually an African slave who laid the foundation for vaccinations in America. There was a slave named Onesimus 300 years ago, who was talking to his master, who was a minister, and smallpox was the pandemic of that time. It was really devastating the world. And obviously devastating Boston. And he told his master, hey, we have this procedure we've been doing in Africa for a long time, where we would take the boils. So smallpox would cause patients to have boils, and they would take a little fluid out of a boil of an active smallpox person, inject it into someone who didn't have smallpox. That would initiate an immune response, so they didn't have as severe a case of smallpox when they got exposed to the virus. And his master went to the medical community, which obviously was all white male at that time, 300 years ago, and said, hey, we have a way to get this under control. Of course, nobody wanted to listen, because nobody wanted to listen to a Black man, particularly a slave. But there was one doctor who said, hey, nothing else is working, we might as well try it. He did the procedure on his son, who had just a mild reaction. And then a word got out throughout the neighborhood that he was doing this procedure. About 300 people got that procedure that the African slave had taught them. And unfortunately, not long after, in Boston, about half of the population got infected with smallpox, which killed about 14% of the people who got smallpox. But the people who got this vaccination-like procedure, only 2% died. So all these doctors who didn't want to listen to a Black man they had to retract, because at that point it was unethical to continue to withhold that treatment. And then they perfected things throughout the years and generation. And then from there, smallpox eventually became eradicated, but that laid the foundation for vaccines in America. So that is something that we as Black people introduced. We've been saving lives for 300 years, but a lot of people don't know that. They think, oh, the vaccine was created to take out the population. No, we created that. Yeah. We can be just as innovative and just as intelligent and bring things to the forefront as them.
Yeah. And I think there's lots of things you said, but I think we need to be reminded that this is not our first pandemic, right? That public health has been a savior in the pandemics before, and there's things that we can do. Vaccines are not new. And that, there is a lot of historical medicine, especially from other cultures and the enslaved population brought over, that have influenced medicine today. So, and even when people think the COVID vaccine, it's nothing about it was new. The technology was there. It was just improved upon and adapted to this particular pandemic. And so the other thing that you mentioned is about innovation. And so I think one of the things that we have learned to do during this pandemic is be innovative and creative and adapt and try to make the best of this very unfortunate situation. And I know you're busy and working, so I don't want to hold you too long, but kind of to that same point, knowing that you have seen so much in these past almost year and a half, what are you hopeful for? What are you looking forward to as we hopefully turn the corner sometime soon?
Well, I'm hopeful that everybody gets vaccinated. And I'm hopeful that people will start to talk to their doctors again instead of getting information from YouTube. And or if you're not going to get the vaccine, please wear your mask, N95 or KN95, which are proven to reduce the transmission of the virus by 95%. I'm hopeful that we can get this virus and this pandemic under control, and that people will start to think more broadly and not just about themselves, and think about, this virus does not care whether you're a Democrat or a Republican or you don't vote. COVID does not care. This is a health crisis. And anybody who has political or financial leanings or using this to, control whatever, should not have this much power during a pandemic. That's just my belief. This is not a political issue. It's about safety and your health. And there is no agenda. The agenda is to save lives and to hopefully get back to a semi-normal life again. Right. So that's my hope.
That is, I concur. And with that, before we close officially, I would like to say thank you. I mean, what you're doing is amazing, and having to deal with people when they're at such a vulnerable state is an amazing line of work, and not everybody is built for it. And so I am glad you are one of those who are. So thank you so much for all that you do. And thank you for joining us and sharing on our podcast today. And I will hopefully be talking to you again soon.
All right. Thanks for having me. It's been fun.
Thank you for listening to Read Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.